All right, you guys ready to get started?
Yep.
Sure.
Okay. Well, welcome everyone, our special guests and our attendees to the Fall 2020 Health Careers Week Keynote Lecture, which is the final event of the week, featuring Dr. Maggie Green, an infectious disease specialist and faculty member at the University of Washington. If you have any questions throughout this lecture, please type them into the chat or the Q&A, and we'll try to get to as many as possible at the end. Introducing Dr. Green this evening is a former colleague of hers and Miami alumni physician, Dr. David Dela. So I'm going to hand it over to you, Dr. David Dela.
Thank you. I have, again, as Tylen said, I'm a class of 91 alum, and I'm a member of the Mallory-Wilson Center Board. And I'm very excited to have the distinct pleasure tonight to introduce Dr. Maggie Green, who's been gracious enough to take time out of her afternoon responsibilities at the University of Washington Medical Center in Seattle to deliver the keynote address this week. Dr. Green graduated from Wesleyan University in 1998 with a Bachelor of Arts in Biology, and then did her medical school at Rush University in Chicago, where she graduated in 2004. Dr. Green then completed a dual residency in internal medicine and pediatrics at the Mount Sinai School of Medicine in New York City, where she was chief resident in 2008, and thereafter she went on to pursue a fellowship training experience in allergy and infectious disease at the University of Washington, where she also in 2012 earned her Master of Public Health degree. And then at the completion in 2011-2012 of her fellowship training, she joined the full-time faculty there at the University of Washington, where she is currently a clinical assistant professor. Additionally, she is an affiliate investigator in the Vaccines and Infectious Disease Division at the Fred Hutchinson Research Center in Seattle. Dr. Green is board certified in both internal medicine and pediatrics, and she additionally has her subspecialty certification in infectious disease. She's a member also of the American Academy of Pediatrics, the American College of Physicians, and the Infectious Disease Society of America. She's received numerous awards acknowledging her achievements over the years and scholarships and research grants that have supported her work along the way. Dr. Green's research focus has largely been on the areas of virology and transplant medicine, and her findings have led to over 20 publications, I believe, in peer-reviewed journals, and have been presented at both national and international scientific meetings. I personally have had the pleasure of knowing Maggie since I joined the faculty at Mount Sinai in 2005, which coincided with the start, I believe, of her second year of residency training. Maggie is an unbelievably skilled and compassionate clinician. She's a brilliant scientist. And to this date, I will say, with hopefully out embarrassing her, that she remains absolutely one of the most outstanding trainees that I've had the pleasure to work with in my over 20 years of academic medicine. She currently lives obviously in Seattle with her husband and their two children. And with that introduction, I'm going to turn things over to Dr. Green. She's going to be sharing with you tonight her experiences with, and I think unique perspectives on, the COVID-19 pandemic, who's someone who's been on the front lines since the very early days in one of the early epicenters in Seattle. Dr. Green.
Thank you, David. I really appreciate such a warm welcome. So thank you to all of you for coming and for your attention today. So I wanted to just thank you for the opportunity to reflect back on what you might be feeling now as kind of pre-health students. And to think about what I was thinking about when I was a pre-med student all those many years ago. But also, I wanted to thank you all for the opportunity to think about this past year in a way that I probably would not have wanted to for a while. Just to start, I know Dave gave such a lovely detailed introductions. As you can see, this is Seattle. It is my home now, but it is not where I'm from. And one of the things I've always been struck by in medicine is how many people seem to know exactly what they want to do with their careers, even before they enter school. So throughout my path, I've just been in awe of people who have a particular interest in a disease process or have a mentor or coach parents or family members who really just help guide them, and they say, oh, I want to be a transplant surgeon, and they sort of attack that plan and achieve it, and everything looks like a straight line. For those of you like me who are not so sure and who remain mid-career, maybe not so sure, that's also okay. So I just wanted to spend a little bit of time to tell you my story. I am from a small, previously blue-collar community on the south side of Chicago. My mother was a welder in the steel mills, and when the steel mills closed down, she went to work at an oil refinery. And I became, like many kids, thought I want to be a doctor when I grow up, and just started kind of going towards that path. Always sort of in the back of my mind believing that at some point I'd get into a wall where I wouldn't be able to go any further. And knocking wood, I feel like with a lot of help and determination, I haven't yet met that wall. So I'm still kind of moving forward. I did want to leave that small, formerly blue-collar community, though, and I decided to go to college at Wesleyan University, about an hour away from where my grandfather lived. And he was one of my favorite people, and I just wanted to spend a little bit more time with him. And so I did. And then after college, I moved to San Francisco and lived there and did clinical research with some really talented endocrinologist and exercise physiologist, and that was my first foray into doing research on human subjects. And then home to Chicago for medical school, New York City for training, and ultimately deciding that I did not want to stay in New York City, and had an opportunity to train at the University of Washington. So I moved out to Seattle. So definitely not a straightforward path. And even since I have been in Seattle, my path has kind of moved around a lot. So I just want to encourage everyone to hear that that's okay, to move around, to figure out and find your place. I have to say that before COVID, infectious disease doctors were not bored. We think a lot and write a lot and study about the problems of multi-drug resistant organisms, particularly bacteria, the limited pipeline for new antibiotics. So as we see more resistant organisms, what are we going to have to treat them with? A lot of us are focused on projects towards ending the HIV epidemic and trying to find those little pockets where HIV transmission is still occurring, and trying to shut those down so that we can actually truly see the end of the epidemic. Many of us are heavily involved in hepatitis C treatment, antimicrobial stewardship, which is mostly in the hospital setting, but also is spreading to the ambulatory or outpatient side of things. And really, these are mostly pharmacists and physicians who spend a lot of time thinking about how best to get patients to get the exact antibiotic they need for the exact amount of time they need it and no longer. And because of our increasing opioid use disorders in the world, but particularly in our country, we see a lot of infections related to intravenous drug use. Many of us are heavily involved in research on health disparities. And as in academics, I'm involved a lot in how to advance the careers of women and unrepresented minorities in medicine. At the same time, in infectious disease in particular, we've really seen a decreasing workforce, partly because for medical subspecialists, we probably work the hardest and get paid the least. So it definitely attracts a different cadre of people. Specific to me, my job is made up of a whole host of different kinds of jobs. So I'm in an inpatient infectious disease consultation service, helping our internal medicine colleagues to treat complex infections, or to diagnose them first and then treat them. I do have an outpatient infectious disease clinic. We do, or did, a lot of travel medicine. So helping people prepare adequately for trips that they're planning. And then if they return and are sick with tropical diseases, we can help treat them and get the right diagnosis. I'm also very heavily involved in a new project called the She Clinic. This is a project that started a few years ago, basically focused on trying to provide primary care to women who are living unhoused, most of whom have polysubstance dependence, so opiate use disorder, often with methamphetamine use, and are involved in transactional sex, which is, in terms of sex work, it's this sort of trade of sex for survival. So for food, for shelter, sometimes for, a shower. These are some of our most vulnerable citizens in Seattle, and we have very few services for them. And so we started a primary care clinic just one afternoon a week to provide empathetic care to these women who are often treated quite poorly in our world. And I think we just counted last week, and I think we've seen nearly 200 women serving people just half a day a week for the last year. I also do HIV primary care, and there I'm focused on the care of adolescents with HIV, and particularly those who are transitioning from pediatric care to adult medicine and wound care. So, many people with chronic wounds end up with infections and need particular care with a subspecialist, and also some antimicrobial stewardship to round it out. So definitely a full career, a busy and often difficult to balance collection of needs and people wanting things from you at different times of the day and night. But we're not all just about our jobs. And so as busy as I was with all of this stuff, I also have 2 young kids. I have 4 old parents. They all live far away from me. I have a partner with whom I'm very close. I am a mentor, a confidant, an advisor, especially, many of those of us who have more empathetic personalities, we tend to take on more of those roles. And those are often not counted in what we think of as what we're spending our energy on. And there's all the relational things that we do for our families and friends. And then there are the things that we do just for ourselves when we're not, thinking about who we are in relationship to other people. For me, that tends to be spending time in the outdoors, hiking, biking, running, sometimes getting to read without falling asleep. So a very, very full and not boring life. And then we got COVID, and everything kind of changed pretty quickly for everyone, and it changed for everyone very quickly. So I'd like to just start with some basics on COVID. Just so that we can all make sure we have the same facts and we're all on the same page. This is an image, sort of a model of what SARS-CoV-2 likely looks like. So it has the severe acute respiratory syndrome, coronavirus 2. And this is called, these groups are called the coronaviruses because these spike proteins on electron micrographs give it that corona appearance. It is most likely came from the horseshoe bat, and likely has been there for decades, is based on the genomic analysis. There may have been a possible intermediate host in pangolins. And of course, looking, my son saw these and he thought this was like some sort of sci-fi movie because these creatures are so amazing. But, and this is really the paper that describes the first cases of coronavirus that developed in China. So these were people who presented with severe pneumonia that was sort of rapid in onset. I know many of you have, maybe some of you have already seen what x-rays look like before, but this is kind of normal looking lung where there's a lot of air, which is black, and bones are usually white. So we see these shadows, but this part of the lung and this entire part of the lung is full of fluid and inflammatory cells. And unfortunately, inflamed, leaky lungs do not exchange gases very well. And so people develop respiratory failure. This is a report from patients in January, and it was published January 24th. So this little timeline kind of walks us through just the very beginning. As you can see, initially things kind of moved very fast. Bronchoalveolar lavage samples, so that's basically someone putting, squirting some saline down someone's airways and sucking it back up to try to sample the airways from patients with this pneumonia. in Wuhan. And by, I think, they identified a coronavirus pretty quickly. By the end of December, China CDC had dispatched rapid response team, and the WHO was become aware. Finally, a few days later, the WHO provided information to its members nations from Chinese officials. So starting to spread the word that this was happening, still quite limited to Wuhan. And the WHO then provided member states more detailed information about the cluster of cases as it became available. By January 9th, the Chinese authorities and scientists have determined that the outbreak was due to a novel coronavirus. And 2 days later, the WHO announced that it had received the genetic sequences and that they would be made public. So this is when laboratories who pay attention to these things all across the world started working on, studying this virus, figuring it out. Many of them started working on, developing a test, especially as, January 13th, Thailand reported a case, January 16th, Japan. So you can see this was definitely already spreading. And on January 21st, the US reported its first case. We'll kind of get back to that in a minute. France reported its first case a few days later. And January 30th, WHO declared a public health emergency. By February 2nd, a PCR diagnostic kit, not kids, sorry about that, was shipped to the WHO regional offices. And at that time, President Trump bans travel from mainland China. The first CDC test kits did arrive in early February to the Sentinel cities, so only to the public health labs and only in cities that were thought to be high risk. Seattle, Los Angeles, I believe San Francisco, New York City, sort of big areas where there was a lot of travel from China. And unfortunately, as soon as they sort of unpacked them and started trying to validate them, they found that they didn't work. March 11th is when the WHO declared a pandemic. So this first case that was reported in the United States was actually from a traveler, a 35-year-old man who presented to an urgent care center with 4 days of cough and fever. He'd recently returned from visiting family, January 15th, from Wuhan. And he had heard about the cases in Wuhan and thought, maybe I should get checked out. And so he actually did a very smart thing. He called the urgent care center first and asked them what to do. And they had him come in, but he was immediately put into an isolation room, and the public health department was involved. I think initially they did admit him into an isolation room in a hospital while they sorted him out. He actually did fine. I think he was monitored very closely because at this time we had not a lot of information about what was going to happen and what the course of COVID would be for patients. And so much was learned just from kind of watching him develop new symptoms, whether it was diarrhea or, when his fevers went away. But after about 3 days in the hospital, he was discharged to home isolation. In terms of our early preparations, this was kind of January into February. UW Virology was, very busy working on a PCR test. So that's a test to search for this from preferably, a nasopharyngeal swab. And we've done a lot of this based on our general flu and respiratory virus research that comes out of Seattle Children's Hospital, as well as the University of Washington. We also have the Institute of Health Metrics and Evaluation, and we started the UW Medicine COVID-19 Command Center. So UW Medicine has, I think, 4 hospitals, and we all sort of work together, but we also have a little bit of independence. We have our different flavors and things we focus on. And they felt very early on that it would be important if we were expecting a large epidemic to organize and get everything together, think about supplies, think about supply chain, think about hospital capacity, and really start to figure things out together. Lots of policies were implemented very quickly. So, Initially, we had, mostly focusing on how we would handle patients coming in and making sure that we were screening for recent travel and also recent symptoms. And then, of course, as things progressed and we knew there was more community spread, the focus became more on current symptoms and less on travel. An interesting part about what was going on so we have the Seattle flu study, which is a really kind of interesting idea. It is a consortium study funded by the Fred Hutch Seattle Children's, the Broughton and Beatty Institute, as well as I think Gates Foundation has been involved. And it was essentially set up to deliver swabs to households all across the area, the region, in various parts, to try to monitor how respiratory viruses, in particular influenza, spreads. And so they were set up and already collecting swabs from people starting, I think, in either October or November of 2019. And so once we started thinking about COVID and that our laboratory had developed a sort of early research test, they went back and started looking at their swabs to see how many of them had had COVID. So the idea is that if you had symptoms of a respiratory virus, you would call, they would mail you a swab, you would collect it yourself, you would send it back in, and then they would tell you or not. They would tell you if they had the flu, but they also were holding on to these swabs to look for different respiratory viruses, and with the idea of kind of developing a map of how influenza during a typical year spreads throughout a region. From January 1st to March 9th, they had 3,524 participants that provided specimens, and 2,300 completed all of the study procedures. And among those, when they went back and looked, SARS-CoV-2 was detected in 25 or 1.1%. Now that number was low, but if you think about this, before March, all of February, we were having community spread throughout our region of COVID. And when they looked at the genomes, they noticed that 15 derived from a single introduction sometime in late January and early February, and was basically spreading in the community undetected. People were, mild disease or moderate disease, but they were negative for flu, and people just were sort of, if they had sought medical care, they were probably told that it was a respiratory virus and they would get better. But then it hit the nursing homes. So this is the first kind of major outbreak we had, and it hit all the headlines and probably national news. This is a nursing home. I'll just mark on the map. So our little hospital and campus is right here, and this nursing home is right on the other edge of Lake Washington, in kind of a small suburb. And it claimed the lives of 13 Life Care Center residents in Kirkland. 31 more test positive. Ultimately, when they started doing review of 911 calls from this agency, they realized the outbreak started probably as early as January 29th, and ultimately 129 cases were identified. 81 were residents, 34 were staff, 14 were visitors, and unfortunately they had 23 deaths. In the sort of look back on how this could have happened, because you can imagine in a small, nursing home, losing 23 residents is terrifying. It's very upsetting to everyone. They had significant limitations in PPE. There was no testing available because there were no tests anywhere yet. And what they found were that staff were working while sick and working at multiple facilities. Many of these staff are, pretty low income, often, working multiple kind of part-time jobs or sometimes full-time jobs, and then would go from one site to the next, doing caregiving. And so that facilitated the spread amongst many nursing facilities in our area. This is my little community hospital where I work. It's a university affiliated community hospital, and we were just busy preparing during this time. We waited And each of us started to do the things that we do when we're anticipating a tough time ahead. Everyone was very anxious. We didn't know what it was going to be like, but we all suspected that it was not going to be good. And so I did the things that I do when I'm preparing for a tough time. So whether that's finals or a difficult rotation, we all have our rituals. For me, I cleaned my desk at home. I made sure all of my bills were on auto pay because I, run a household and didn't want to pay late fees. I made sure all the laundry was done. I called my parents, and the hardest thing for me, actually, we had a little vacation to Borrego Springs in California planned, and I, looked at the data that was coming in, and I canceled the vacation because I knew that in late March I would not be traveling anywhere. And then on March 3rd, I got a call from the ICU about a 55-year-old man who's admitted overnight to our hospital with, respiratory failure. Now, just to kind of underline how shocking this was to me, everyone we had seen with this virus already, and it hadn't been many, were elderly with comorbid conditions. And so you have this idea that these were people who were just super vulnerable and already very sick, and this virus kind of just pushed them over. And that was my initial impression back March 3rd. But this man was vigorous. He was healthy. He was working. He was a former Marine. He was fit. He did have diabetes, and so that ultimately puts him in that category of having a, underlying condition, but it was very well controlled. And so it was just really, it was shocking. It was to see him get so sick. And the ICU had called me wondering about treatment. And of course, our colleagues at the hospital caring for most of the life care patients, that initial nursing home, had gotten with the FDA and a drug company called Gilead an emergency investigational new drug application for a new antiviral drug called remdesivir. I just want to pause and talk about treatments for COVID-19. There are still currently no FDA-approved treatments for COVID-19. In March, what we talked a lot about was supportive care. So that's, oxygen supplementation, it can be positioning, it could be, certainly ventilation if needed, but essentially there are no medicines or drugs that we give to people that are licensed for COVID-19. When we think about how we like to treat people and what the ideal is, you will hear, or maybe you have already heard a lot about what practicing evidence-based medicine. And the gold standard of that is randomized clinical trial data from multiple sites. So you recruit people from all over the country. In a pandemic, you can recruit people from all over the world, and you randomly assign them to a control group, which is usually, in this case, where there's no proven treatment. You randomize them to a placebo or the drug that you're trying to study, and you try to keep everyone as blinded as possible, and you collect the data, and you analyze it, and then you know whether your drug actually works. And I have to say, in my prior experience of doing randomized clinical trials or participating in them, these can take a long time to do. Oftentimes people will be, enrolling and participating in these studies for at least a few years. The difference here, of course, is that this is a pandemic, and so there were so many people getting infected that you actually, if you allowed enough sites to enroll patients, you could actually get the study done pretty quickly. Below the gold standard of what we consider the best clinical evidence, are non-randomized but still controlled trials. Below that are sort of case control or cohort studies. And so that's where you have like a group of people where you give the drug to and a group of people that you give placebo to, or you just give kind of standard care, and then you compare those two groups. But there's always this concern of bias of whether maybe you gave the drug to the sickest patients and you gave the placebo or the standard of care to the less sick patients. And so does that, does that skew your interpretation of the data? And then finally below that are case series and case reports and opinions. And unfortunately, early on, what the data that we were getting from China was really all in this case series, case reports grouping, where we just had no idea, and really ideas were flying all around. Just to be thorough, above the level of evidence of randomized controlled trials would be a meta-analysis of multiple clinical trials, where you take all the data from multiple clinical trials and reanalyze it, and then that's even more powerful. But what we had were these. We had these case series and case reports that, hydroxychloroquine might be useful, or hydroxychloroquine with azithromycin, or an old HIV regimen, lopinavir, ritonavir, has shown some antiviral benefits. Will steroids work? They did not work for original SARS-CoV-1, and they certainly seem to make influenza worse, but maybe they would be helpful for COVID-19. Tocilizumab is an IL-6 inhibitor, so it's another immune modulator. Remdesivir, convalescent plasma, so, giving plasma that has been donated from people who've had COVID but then recovered, to see if that might make a difference, so a way of giving them some passive immunity. Ruxolitinib has been considered. That's another immunomodulator. And then we've heard now more recently about Regeneron's monoclonal antibody. So there were all these data coming in, and we really had no idea how to assess the validity. Everything was being released to what's called preprint servers. So many of us, we rely on peer review. So we expect that when I produce a paper of research, I send it to a journal for publication, and then they send it out to my peers and other researchers in the area, who then have an opportunity to ask more questions and criticize and tell me, this just doesn't fly. I don't know why, or, it's not making sense. Can you analyze it this way? And really prove to me that what you're saying is true. And we weren't seeing any of that. Everything was just being released to preprint servers. So they had not been subjected to peer review. And it was being, I had patients asking me for these drugs. It was quite crazy. Very early on, I knew I would need help. I was one of the only people seeing patients at this hospital with COVID. I will tell you that our infectious disease faculty has 4 members. One of ours is the head of the hospital, so he was a little bit busy. Another is the head of infection prevention here, so he was also busy. And then a third was older, and I think we were very much trying to keep him away from COVID initially, because we just weren't sure that it was going to be safe. And so I was seeing every COVID patient that came into the hospital, and without any information and without any time to sift through the information, we all knew that we would really need to work together. And I really am so grateful for my faculty members at the University of Washington, because what we did was try to develop some treatment guidelines so that at each of our hospitals, the care that patients would receive would be similar. And so this guideline group, in addition to myself, contained faculty from infectious disease, pulmonary critical care, cardiology, hematology, oncology, pharmacy, and transfusion medicine. And every week we would sit together and talk about the data that had been released the prior week. And I can't tell you how many times the hour before we were set to meet, there would be a new press release about a new treatment. And we'd have to kind of rearrange everything and try to find out more information, because data was coming out in such unusual ways, and it was often incomplete. And yet we were trying to make decisions for our patients based on what we could find. Let me tell you a little bit about remdesivir. I think hopefully many of you are familiar with RNA polymerase and RNA replication. So this is SARS, a sort of mock-up of SARS-CoV-2. It's an RNA virus. And so to replicate, nucleoside triphosphates are incorporated into the elongating strand by an RNA-dependent RNA polymerase. So this is sort of the molecular side of things. And you can see this is the structure of remdesivir, and this is the structure of ATP. You probably all remember that from organic chemistry. See, you will use it again. After diffusing through the cell membrane, the protecting groups of remdesivir are cleaved, it's metabolized, and then phosphorylated into the sort of active drug. And then what happens is that it competes with the other nucleoside triphosphates. And eventually, after it it outcompetes it, and then after the addition of 3 more nucleotides, the remdesivir triphosphate terminates the chain synthesis. And so it decreases RNA and viral replication by that mechanism. So here's Mr. Raymond. He was in the news, and this is actually his the photograph that his wife took of him when he was getting better. And I had to call his wife when he was intubated, you know, very sick in the ICU, and ask her if she would like for me to apply for a compassionate use emergency, you know, new drug application for her husband, for a drug that I'd never used before, whose side effects were really unknown at this time, although it had been given to a few patients under the same mechanism. And had also been used it had been studied in other viruses in the past. So we did have some beginning clinical data to indicate that it was likely safe. We had no idea whether it would work. And she's on the phone, and remember, this is with COVID, she was actually sick, so she couldn't come in. No one, you know, could really be close with him or communicate with him very well because we had all of our PPE on. And he was so sick that he had to be pretty sedated in order to manage the ventilator. She agreed, and so we did that. And I called, and they approved the emergency use. And they said, okay, well, ship it, overnight ship it. You should get it March 5th. I gave him his first dose, and then later that afternoon, I got a call about a 24-year-old man who was in the ICU with COVID. And we did the same thing. But again, you know, I just want to stress how different this was than what we expected in terms of who would be getting severe COVID. And it was just really hard. This man's mother was homesick. This young man's mother was homesick. His sister was actually hospitalized, but, you know, was not as sick as him. And so when we were trying to get all of the consents together, you know, trying to call all the different people, I was sort of shocked when his mother told me, I think it's better if you call his sister. And the number she gave me was her hospital room so that I could call her while she's in the hospital recovering from her own COVID. And I think she has a different last name than her brother. And so I didn't recognize them as being part of the same family. And then on March 10th, a 72-year-old woman, very active, still working. She was a restaurant owner, was admitted again similarly. So within the matter of a week, I talked to the FDA, I don't know how many times. I've never called Washington, D.C. so many times in my life, to get permission to give these people this new antiviral medication. On the Friday before this last woman came in, I learned that compassionate use would not be available anymore at sites with access via a clinical trial. So this is the way of drug companies to say, you know, we really want to find out if this drug is going to work. And the way to do that, they recognize, is to do a clinical trial. And so they were saying, if you are going to have the clinical trial, then you won't get it for compassionate use anymore. And that was hard for me because although the University of Washington, different hospitals, we are all linked when some of us are sort of technically the same. Ours is a community hospital, and we don't have a big research infrastructure like the more academic ordinary care center. And so the plan was for for the clinical trial to be done at the two hospitals that are the more research-oriented hospitals. That would be the University of Washington Medical Center, Montlake, and Harborview Medical Center, which is our trauma center and kind of our large public hospital. And so I knew that I would no longer have access to this drug once the clinical trial opened. And I think I opened my big mouth and sent my division head a short email saying, you know, boy, if you guys are going to have this trial, should we be transferring our patients to these hospitals so they have access to this trial? And she said, let me think about this. And next thing I knew, I was now going to open the trial at my little community hospital. And I would be the investigator for this site. And we had an investigator at each of the sites. And we had our site initiation visit the next week. Again, this is like rapid speed for clinical research. I can't even stress to you how fast everything went. And then, of course, 2 days later, Seattle Public Schools closed. And so now I'm struggling to figure out childcare, working, 12 to 15 hours a day. And so it just really all began to feel very real. And this is the census of my hospital at the early part of the pandemic. So I think the first value here is kind of late March. But between March 13th and April 3rd, I enrolled 14 patients into the randomized controlled trial, which is very amazing in a community hospital. If you think about it, I was asking nurses and pharmacists and, physicians to do something outside of their norm, something extra at a time when everything felt so extra, right? We had so much PPE, we had so much stress, we had so much anxiety. And I was kind of like, okay, we're starting this new clinical trial and these are the kits and the phlebotomy will have to draw the blood and, really trying to coordinate everything. And I realized that the only way that I could do that was just to be here to answer every little question, to make things easy, to facilitate things getting done, and also just to be the person so that they knew that if they had a patient on clinical trial, there was no real hierarchy. They could just call me and ask me the question they had so that they felt like they knew how to, do what they needed for the trial, get access to the care. So I got, pages from the lab at 5 a.m. or calls from the nurses at 2, and just constantly throughout the day. But by the end, I had the nurses calling me to say, hey, I think we have a new patient for your trial. So as much as it was very challenging for them, and I'm so grateful for them being willing to kind of take that on, I also think it made them feel really good to have something more to offer than oxygen. So it was very interesting. Some of the things that we learned, though, like figuring out how to, document informed consent. Like you can't, in a viral pandemic, a respiratory virus, you can't bring a paper into a room for someone to sign and then just take it back out. So all of these things we just really had to think about and plan for. But I also, in this early time, was starting to feel a lot of anxiety. I mean, I was working really hard and everyone was, and it was still getting worse and worse and worse. And you really felt like you just wanted to know how much worse it was going to get. We were sort of like on this part of the slope, and we just didn't know how much higher we would have to go before we started to get better. I want to diverge a little bit to talk about the other person who worked. So during that time, I think I worked 60 days in the hospital. I didn't, I left, but I worked and came to the hospital every day for 60 days. And so did my colleague. And this is our one palliative care provider in the hospital. And he developed this early intervention program because based on the data we're seeing, we knew that people who were elderly and had comorbid conditions, if they required ventilation, their chances of surviving were almost zero. And so he did between March 1st and May 3rd, 112 emergency department palliative care screenings. He basically had the ER call him for every COVID positive person who was coming in with, who was elderly and had at least one comorbid condition. He personally managed the comfort care of 36 patients who were managed inpatient, so they were admitted, but oftentimes they would require high levels of morphine to maintain comfort as they passed. We performed no COVID CPR, which, you know, performing CPR is always very difficult, and you only want to do it when you think you have a chance of bringing that person back from the dead. And so and especially during with a respiratory virus, the additional increased risk to staff being, you know, performing CPR was really something that we thought a lot about and talked a lot about. So there was not a rule that we would not perform it, but because of his work in, you know, understanding the code status and the wishes, just being willing to talk to people and figure out and make sure that our plans and treatments were in line with the patient's goals and values was critical. In all of our COVID deaths, and we did have a lot, were transitioned to comfort care prior to death. And that is just, I think for me, very meaningful. But I was not okay, and neither was anyone else. So as I said, I was working 12 to 15 hours a day, 7 days a week. Our patients were dying. And I'm used to patients dying sometimes, it's true. I mean, I take care of people who have sepsis, but it felt very different. We were seeing patients die who had no health problems. And we were seeing patients die without the benefit of having their family holding their hands next to them. I also, you know, everyone needed to talk all the time. So just walking down the hallway, my colleagues would, you know, kind of want to vent or tell me about their anxieties or ask me a question about, you know, well, what is the thing that I should be doing? And is this airborne or is it not? I couldn't, you know, there were so many things we just didn't know early on. And of course, you know, my children missed me and wanted my attention. And I was very worried for my family's safety. So all of us in the hospital, we developed our own kind of rituals and routines about, you know, what we did kind of before coming to the hospital, when we left the hospital, to try our best to protect our families from getting this infection. So, you know, I'd taken off all of my jewelry, including my wedding rings and, you know, earrings, and just, you know, my hair was tied back and protected. I wore scrubs every day that I changed into at the hospital and changed out of before I left. I showered as soon as I got home, and ultimately probably there was some part of that probably wasn't necessary, but it was just, we just didn't know. And I think it did help with some of the anxiety. But I was crying a lot, you know. It was very sad to be losing so many people, to see the suffering, not just in the hospital, but of our community members. So many people, you know, I work with a lot of unhoused populations. And so, you know, all of the day centers were closed. So the one place that they could go to feel human, get a shower, do their laundry, all of that was shut down. People, of course, so many people were losing their jobs. Personally, I was eating poorly. I was not getting any exercise. I was beginning to isolate and have some behaviors of avoidance. So I was, you know, this shower started as like a quick shower when I got home to kind of make myself feel clean before I sort of entered my family life. But as the stress increased, I noticed I was taking longer and longer showers, and it was just really hard for me to re-enter that family mode, especially, you know, with young kids. They really need a lot of attention, and I didn't have much left for them. And I was beginning to have some maladaptive coping. You know, you think about like going from having an occasional glass of wine with dinner to suddenly thinking about like maybe having a glass every day after dinner, or, you know, again, that super long shower. You know, I heard a lot of my colleagues talk about sort of working until after the kids were in bed so that they, you know, really just wouldn't have to deal. So, you know, among people feeling burned out, you know, I was definitely starting to show the signs. And then we started hearing these reports from Elmhurst Hospital in all of many of the large public hospitals in Brooklyn and Queens and New York City. And I tell you, this man, Joseph Lieber, is one of my personal heroes. He's a brilliant physician, incredibly humble, has been working at Elmhurst Hospital for most of his career. And, you know, aside being a dedicated teacher of medical students and residents, is just a wonderful physician. And to see the suffering of this hospital where I had trained. So it's like I knew how busy that hospital was even before COVID. And I couldn't imagine seeing the lines of people, you know, waiting to get inside to get care for their disease. It was just really horrifying. And it really just, it a little bit broke me. And so I realized I needed to do a few things to take care of myself. And for me, self-care is not I guess it was taking a hot shower, but I would just say that, like, there are times I know that physicians and medical professionals in particular are at high risk for addiction. They're at high risk for burnout. We know that we have an increased risk of suicide compared to other professions. And so when you are entering a health career, you can't think that that does not apply to you. And so I sort of recognized that I was not taking good care of my mental health. And I just started to do some things, little things that would help me. So for me, that became walking every evening. So I would, come home and eat dinner and then go for a walk, listen to a podcast, listen to nothing, but just get some exercise. That kind of meant that I would be spending less time with my children during the week, because sometimes I missed the bedtime routine, or sometimes, I got home too late to see them, but then I would go out for walking. I stopped drinking altogether. I just didn't think I needed anything that was going to be altering my perception of things. And I really just felt like I needed to be clear. I started a formal gratitude practice, which is something that I had done, at different times in my life, but has been shown to really be helpful, just to sit down and take 3 minutes at some part of your day and take a pen and a piece of paper and just write down things that you're grateful for to kind of reframe your mind. I did set up a weekly Zoom call with some friends of mine who are also colleagues, because one of the challenges I had was that my husband is not in medicine. And so he had a lot of questions too. And I would come home from a day of answering questions about COVID, and he would have his questions, and we would have things that we needed to talk about. And I needed just some time to be social with people who didn't have questions for me about COVID. And so I set that up. And then I set a goal of staying away from the hospital 1 day per week, so that I could still do a lot of the work remotely, but at least 1 day a week. And I was still on call all the time, but at least 1 day a week, I would just not walk in the doors. And that seemed to help a little bit. Also having to cut off social media and news, because again, there wasn't good news coming, and it wasn't helpful. So these are all things probably maybe you already know these things, maybe you've talked to other people about them or have heard other people talking about them over time, but it has never been more important for me than during this time. I think in all of my training, I've definitely had hard months. You have a hard rotation in residency, or you have a rough few weeks, but you kind of get the sense, or I had developed the sense, that I could do anything for a month, or I can do anything for 8 weeks. And then, because you always kind of know when that rotation is going to end. But for this, we just had no idea when it was going to end. And we certainly had no idea when it was going to start getting better. From this, we did have, initially the compassionate use data came out, which again is not the greatest data, right? Because there's no control group, but it does show that people didn't get worse with remdesivir. And then finally, the preliminary report. The final report, I think, was just published last week, so maybe you guys have already seen that. But basically, of the clinical trial, indicating, so 1,063 patients were randomized, and the median recovery time for people who had remdesivir versus those with placebo was 11 versus 15 days. So an average of 4 days. In the final report, it did kind of look like a fifth day, so maybe 5 days sooner, but really no mortality benefit. And so again, this felt like, okay, we have this drug and it does help. It seems to only help in people who are, sicker. So that would be receiving oxygen. Those have the greatest benefit. It was unclear if there's any benefit in patients who are receiving higher levels of oxygen support, so needing to be on the ventilator. And that may be just by then their lungs are already so damaged that the antiviral is not going to make a difference. And the help started to come in. So then suddenly there was the NIH treatment guidelines, which were, I think, very sparse at first, but they were meeting just like we were in our little tiny group of UW faculty. They were meeting regularly and really updating the data, and they started getting access to all the clinical trial data a little bit ahead of time, so we could give a sense of, even if things were not published yet, what directions things were going. And so we at least had a reference where we could go to find help. Similarly, the Infectious Disease Society developed their own guidelines. And with time and lots of research and dedication from patients who've participated in studies and family members who've consented for their people to be in these clinical trials, we've really kind of narrowed the field right now for COVID treatment. And currently there are still no FDA-approved treatments, but I expect remdesivir will be approved. There's also been the randomized clinical trial for tocilizumab is still either ongoing or just an analysis, so we haven't seen that data yet. Steroids, particularly dexamethasone, does seem to work for people who require oxygen. There's an ongoing clinical trial, so another randomized clinical trial for people to receive convalescent plasma. Ruxolitinib study, we did that study. We were participated in that study here, and that is, as I said, an immunomodulator, and that study just completed, so we should have that data soon. So it's just very helpful to kind of figure out in maintaining our commitment to using scientific method and data that we really believe in to figure out what's the best way to treat patients. And again, the monoclonal antibody from Regeneron is still under treatment. The tocilizumab story was actually a pretty good lesson for me, because this is something, again, that was based on a case series of patients from China, and it looked like people who had developed this kind of hyperimmune syndrome during their COVID course. So that would be, patients have this initial course of either URI symptoms or fever and flu-like illness. And then maybe 7 to 10 days, they start getting worse. They start having high fevers. Their inflammatory markers in their blood go up, and they start needing more oxygen. And I had seen that in a handful of patients. And based on this kind of initial data, plus on some, mechanistic understanding that if this is just immune hyperactivation, then giving an immune modulator should help. And so I gave it to a handful of patients. And after a few patients, I got a call from the pharmacist saying, we only have 25 doses or so of this in our whole system. If this is going to become the standard, then, we've got to figure out how to get more. And of course, this was at a time where everyone was trying to figure out how to get more of everything. So our supply chains were limited. And the UW Medicine quickly, we sort of sat down and thought about what it is when you have scarce resources. We have a lot of colleagues that, do work in parts of the world where resources are more limited, and they, we have ethicists. And so they were all sort of thinking hard about this and talking hard about this. And it was good to let these people with the experience and brilliance that they have inform how we were going to be making decisions every day, that I really, trusted that I was going to be, making the right decision. And so for tocilizumab, one of the first things we did is one of our faculty member who was not seeing patients and had some time to do this, just looked at all of the patients who received tocilizumab and compared their course to all of those who weren't. So, again, for a few weeks, tocilizumab became very popular. But when we actually look, this is kind of a busy slide, but it essentially tells you that it doesn't really help people recover quickly. It doesn't really help people avoid ventilation. But that's my bias. That was what I thought would happen. And so it was really helpful that someone made this so I could kind of see, boy, this isn't a randomized trial. It's not the highest level of evidence, but I'm not really seeing a signal that this is worth all of the hand-wringing we're doing about figuring out who should get this limited resource. And so I stopped prescribing it. I want to get you back to our patient. That initial 55-year-old man during this time sent an email to his ICU nurse. So he survived. And not only did he survive, he was on the ventilator for nearly 3 weeks, but he was strong enough to be able to discharge right back to his home. I think his wife was very capable of taking care of him. And 1 month later, his primary care ICU nurse forwarded an email he had sent to him from the top of Mailbox Peak. And I don't know how many hikers are on the call here, but Mailbox Peak is one of the peaks in the Cascade Mountains. It has the trail is a 4,000-foot elevation gain. So it's one of the steepest in the Seattle area, 9.5 or 9.4 miles round trip, and about 850 feet per mile on average. But the last half mile is killer. It's 960 feet in a half a mile. So really steep. A challenging peak, I would say, for me on the best of days. And this man did it, 1 month after almost dying from COVID-19. But the ukulele was a clue to something we had all only figured out weeks later. That 72-year-old woman that I had admitted a week after him was the owner of a local restaurant in our community called the Kona Kitchen. It's a Hawaiian restaurant. And she and her husband actually both died of COVID in our hospital. And they would have a ukulele club come to their restaurant, and everyone would sit around inside and play ukuleles and sing. And we learned that, there was no, I think, public health investigation, but just from kind of knowing the community, knowing this woman's daughter and talking to her about it, that about half of the people who had attended the last group meeting, which was in mid-February, had gotten sick from COVID. In early May, things were better. And everyone was starting to feel like, okay, we have maybe rounded that corner. Yeah, who knows, it can go back up. We have to stay vigilant, but maybe we flatten the curve. And then and I remember that because on May 5th, the video of the killing of Ahmaud Arbery on February 23rd went public. And I remember being so grateful that I actually had the capacity, because of these, because of the break we had gotten and because of these sort of self-care activities, I was able to actually talk to my 6-year-old about this and what it meant. And I don't think I would have been able to do that a month prior. And I began, and then May 26th, of course, the video of the murder of George Floyd was released and went viral. And then 3 days later, protests in Seattle and around the world. And I know that the images of Seattle in protest have been all over national and international media. I kind of began obsessively watching the live streams of this journalist. His name is Omari Salisbury. And just to bear witness of what I would say just courageous and peaceful protests that were happening in our city streets to protest police violence and racial injustice. And I think it was really hard to kind of figure out what was going on. Those of us in medicine were very nervous about these protests. How would this affect the spread of COVID in our community? And, will we go back to these sort of March and April numbers or beyond? and certainly just trying to figure out, along with everyone else, what that meant for our community. I will say that this is also the 10-year anniversary of the murder of John Williams by Seattle police. And so, Seattle police force has already had this, I think, painful history of excessive force. John Williams was a native wood carver who was crossing the street carrying, one of his small wood carving knives. I think the blade was about that long. And he was crossing the street in a crosswalk, and I think it was even with the light. And a police officer who was relatively new to this force, I believe, pulled over, saw him pulled over, called at him, yelled at him to drop his drop his knife. And when he didn't drop his knife, he was shot. And it turns out that Mr. Williams was hard of hearing very severely, and so would not have heard any of the yelling. And so this was just a very kind of painful episode, because he was a highly respected member of, the Native community here in Seattle. His carvings and totems are all across our city. And so it was just a very difficult time for us 10 years ago. And then for this to be the 10-year anniversary happening. So the Seattle Police Department is still under a consent decree with the Department of Justice for excessive use of force. And then we've also had other sort of very high profile, examples of a failure of our police force to de-escalate. And I think that is one of the things that we're just really trying to figure out, is trying to establish, like, yes, of course we need public safety, but what does that mean in our city and in our community? When things didn't get worse, I planned a vacation. So I just want you to know, here's a little island. I don't know if you can see up in here in this tiny little map, there's a tiny little island. 4 nights, 5 days in a tent with my children. It's probably not everyone's idea of a great vacation, but for me, it's what I needed. I turned my phone off. I had no email, and I asked for 30 minutes of time alone each day. Now, I didn't get that. I think I got 20 minutes on a stand-up paddleboard, paddling away as my children screamed and tried to swim after me. But still, I think the importance is just figuring out, I think it was helpful for me just to ask for that, to say, this is really important for me to have some time to heal from these previous few months, and to try to have some time to reflect. So where are we now with COVID? I'm sure many of you are familiar with these numbers. This is from the WHO coronavirus dashboard. So globally, as of yesterday morning, there were 37 million confirmed cases, including over, wait, did I get that right? Yeah, 1 million deaths worldwide. And if we look at our CDC data, and I chose the map, I think in order to look at the hot spots a little bit better, I chose the map that shows us the cases, and deaths per 100,000 people. And so we see right now the current hotspots, unfortunately, are in the kind of plain states, North Dakota, South Dakota, Montana, also Wisconsin, and this area. And I think for me, this is really has been one of the most difficult things, is that we, at least in Seattle in the very beginning, in March and April, when things were so bad for us, they didn't seem, and it was bad in most of the big cities. It didn't seem like it was that bad everywhere. And I think I really had hoped that people would learn from our experience and see how to avoid this in their own communities. And I think our divisions in our country right now are so strong that people see us in Seattle or New York City as just so different from them, that this virus would behave differently in their communities. And I'll say that we even saw that in our own state. So this is Washington State. And again, we're still seeing a lot of activity in the more densely populated areas. But also in some of the more rural areas. And I'll show you on the next slide. These are our confirmed case counts. So this was the early peak in Seattle, and we've, definitely King County and Seattle and the urban areas have contributed ongoing cases, but this spike in July was really focused on Yakima County, which is more of a rural area. And I think we just saw, I don't know, it's a little bit difficult to say. I know that I have a patient who gets his HIV care from me in Seattle, but lives in Yakima, and he drives 4 hours a few times a year to see me. But he called me and said, "Doc, no one is wearing masks here. What do I do?" And so just this idea that even just across a simple mountain range, but in your same state, the message that we need to stay outside, isolate, not be inside with groups of people wasn't resonating. Yakima County also, has a lot of agriculture. And so there are a lot of people who live in congregate living, so multi-generational households or just like multiple families living together. And certainly we also know that that facilitates spread. So that was a lot of work. And even in our hospitalizations in the summer months, many of them were transferred in our hospitals. Many of them were transferred from Yakima County because they were above their capacity to care for patients. Again, our hospitalization counts have not peaked again, even though our cases have. And so, that sort of, I think, goes with the trends we're seeing nationally, where we're seeing more infections in younger people who are less likely, but not, it's not impossible, right? Less likely to need hospitalization and, less likely to die. So again, we still see way more deaths than we want to. But less than we were seeing at the outset. Here in our state, again, we know that older people make up a higher percentage of those that are hospitalized and die from this infection. We also see that while men and women are equally likely to get COVID, men tend to do a little bit worse. Something about the genetics of our immune systems just make it more likely that men are going to get sicker from this infection. And then we don't have great data about this from Washington, but we know that nationwide Black people are dying at least twice times the rate of white people. And so this is something that is really hitting Black communities, Hispanic communities, much harder than it is other populations. And that certainly needs to be explored more. And we really need to spend more attention to figuring out how we can get, more access to testing, more access to care. In terms of current challenges, I've already kind of mentioned the politicization of prevention has really been devastating for me to watch. Because I don't want everyone to have to go through the same learning process I went through. It seems unnecessary. And so, I beg all of you to wear a mask and social distance, wash your hands, and this is all of us together. In terms of preparing for we're spending a lot of time right now preparing for the COVID flu overlap. So, really being ready to ramp up capacity in our hospitals again as we start to see our first flu cases. We know that from data in the Southern Hemisphere, which is just coming out of their flu season, that their flu season was lighter than usual. And that may be because of all of the social distancing that's already happening, but it's not guaranteed. So we're really preparing as if this is going to be just as bad, if not worse, than last spring. So definitely not taking any vacations this winter. Get a flu vaccine, all of us, please, if you can. And then, learning to keep myself well. And also just, I felt the importance of sharing that with my future colleagues, all of you, so that you understand that we are all human and we are all kind of at risk of getting sick, whether that's physically or mentally, especially under the tremendous amount of stress that we're all experiencing. And I think, one of the unique things about this virus is that I think it's affecting so many people, but all in different ways. And so we really had to develop our listening skills and our empathy skills to be able to say, wow, the way this is affecting you is so different than it is affecting me. You know, I'm getting a paycheck. I'm going to work every day. So I don't have this, like, I'm, you know, stuck in my house all the time kind of anxiety. But that it doesn't make it any less than what you're feeling. And so really trying to learn to be with people and appreciate the diversity of all of our experiences and support each other as best we can. For me, that means trying to spend some time in the next few weeks to come up with a winter mental health plan, because it gets very dark here in Seattle. And so walking and running is going to be challenging for me. I think I just found a bike trainer that I can hook up my bike to and just ride in the living room after the kids go to bed, because I'm going to need exercise to get through this next phase. And I will show you that, you know, of course, we have the environmental degradation as well. So this was actually a photo taken in Seattle just a few weeks ago when we were hit with the smoke from some of the wildfires in Oregon and California, and less so this year in Washington. But, you know, it was so hard for us, after telling everyone to spend as much time outside and it's fine to be outside, to suddenly have to say, actually, everyone, you have to go inside. So that is the end of my presentation. I think I'd be very happy to take questions now, if you all have questions.
Tylen, I know you I see a few questions in the chat box. I don't know how many you have beyond that. Do you have many more beyond that, or things that came in beforehand?
Nope, I have one from the Q&A, and I have one in the chat.
All right, so that leaves a little bit of time. I guess if it's okay with you, I'd like to jump in and make maybe one or two comments. I'll let you ask those questions, and I have some follow-up questions if that's okay. We have till 8, right?
Absolutely, yep.
You're good for another 13 minutes, Dr. Green?
Oh yeah.
So Maggie I had no idea exactly what course this was going to take, but I thought she did a fantastic job. That was a lot of information in a short period of time. And it looks like most of the participants have been able to hang on. I guess I want to reiterate a few things that she said at the end. I guess most importantly, and I know in academia we have to be a little bit careful about politicizing issues, but I feel very strongly as a physician, and obviously Dr. Green does as well, the fact that this issue has become politicized and weaponized in a way that it has been very disappointing to me. And I guess what I hope that you guys as current scientists and future healthcare professionals might have gathered from this talk, and again, I don't want to reference politics, beyond saying that a couple things jumped out, and a couple things that you're hearing in the news over and over and over that I think Dr. Green was able, through some data, but more importantly, her just personalized experiences, to debunk is this has not just been a situation that's affected the elderly, right? Kirkland had the nursing home outbreak with 13 dead, but the patient, I forget his name, that climbed up to the top of the mountain.
Mailbox,
but yeah, he was a 55-year-old healthy man, right? And all these people that wait on you with the burden of seeing your patients die and not really being able to necessarily do anything for them, they weren't all old patients who were going to die anyway,
no.
Right? Many.
No, and even, yeah, I mean, even, you know, I think one of my saddest patient she was old, but she did not live in a nursing home, but what her hobby was to go to nursing homes. And, you know, so she's a very active elderly person, and she would go and help older people with things. She would take them to appointments and bring them groceries and, you know, do all sorts of things. And I think that's what we've seen even in our community, is that it's the caregivers, you know, it's the people who are out there taking on this risk, who are getting sick. And unfortunately, she had no medical, I mean, other than being old, she had no medical problems, no medications, but she died. And it was very upsetting. It was very upsetting.
And again, even as a future healthcare provider, hopefully all of you listening on the call, I hate to say this expression, but even if it was just all the patients in the nursing home, those are still someone's grandparents. So let's not be dismissive of lives. So I think trivializing this condition, this pandemic, away as something that just affects the elderly, first of all, is frankly not true. And the elderly still matter. And if you're going to be a healthcare provider, you hopefully embrace that notion. The second thing I want to say around a semi-politicized issue that I don't want to politicize is what Dr. Green showed you in this last hour and 45 minutes is she pulled back the curtain and showed you what the life of an infectious disease specialist who's lived in a hot spot during this time, what her life has been like. And I think it's important to remember the patients are central to this, but the life that Dr. Green has led the last 6 months, 7 months, 8 months, not only fighting for her patients, but trying to take a step back and understand, letting science lead the way on trying to figure out what's going to work to save patients at large, and the impact that that's had on her personal life and what that's meant. She's just one of many, 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 many people to whom that applies. And so we owe it as members of a society to take this science as a real thing, listen to science, and to appreciate what people like Dr. Green have done to try to make sure that we're all safe, and not act in an irresponsible manner. Every time you don't do something that you should be doing to limit the spread of this contagion, not only are you putting other people's lives at risk from a health standpoint, but you're being completely dismissive and indifferent to the efforts that people like Dr. Green are doing to try to keep everyone safe and healthy. And I think that we should owe people like Dr. Green a debt of gratitude for what they're doing and take this seriously. And I guess the last thing I want to say along this lines, and then I'll get off my soapbox, is let's let science lead the way. As Maggie pointed out, there's all kinds of different levels of evidence. Again, this wasn't an epidemiology course, but understanding that randomized controlled trials are the gold standard. But sometimes you have to look at case series. But what you really want to try to do before you start shouting out that hydroxychloroquine's the cure is let science lead the way on that. Because if you don't, you're never going to know the right answer. And it might be you that's in the hospital or your loved one that's in the hospital. And the opportunity may have been missed to find the right answers that's going to help everyone kind of get through this in the best possible conditions. So that's my initial kind of, I don't want to politicize an issue, but it's been politicized by others. And so I'm going to try to take the political sting out of it. Look behind the curtain that Maggie's drawn back and realize this is a real issue. This affects a lot of people's lives, not just because they're sick, but because they're putting themselves at harm's way, and their family are being put in harm's way to try to help all of us that get to live with the ease of not having to worry about this until our time comes to be sick. So that's all I'm going to say about that. And then Tylen, I'll let you ask the questions that have been asked. And then if you have a few minutes, I'm going to ask one or two other quick ones, and then we'll let everyone go.
Yeah, great. So we only have two that came in. The first one was, why were nasal swabs decided for the COVID test? Are they more accurate than throat saliva tests?
So as far as we know, in general, from studying respiratory viruses, so like respiratory syncytial virus and influenza, the nasopharyngeal swab is more sensitive. So that means that you are, if the virus is there, you're most likely going to detect it more likely than if you just do a nasal swab. So that's why they started with those. Now, of course, they're super uncomfortable. I don't know how many of you have already had at least one COVID test. Yeah. But it's not fun. And also, it would be much better if we could just do a nasal swab. And so there have been studies trying to look at whether, nasal swab or mid-nasal swab is enough. And you lose some sensitivity, but it's unclear how important that is right now. I think the saliva tests are still a little bit further back, but they may be, whatever you lose in sensitivity, you may gain by being able to do them rapidly and not needing specialized swabs and media to do them. So there may be this sort of balancing act that we're going to have to do together as scientists and the community to figure out, okay, if we're going to have like a widespread testing program, which is what we needed from the beginning, it might be okay if you don't have the most sensitive tests, because chances are you're going to be tested again in a few days, right? If you're testing everyone all the time, then if you miss one day, maybe you'd get it the next day. if it's a false negative test. But initially, it's just because it's the most sensitive test.
Thank you. Do you often have to battle with big pharma?
Battle with big pharma. I don't have much engagement with big pharma. So, I'm, as Dave says, I'm just one of thousands of infectious disease doctors that, come to work every day. I think we have to have a good relationship with pharma because we have to have the new antibiotics and the new drugs, and really they have the infrastructure to develop these. But on a day-to-day basis, I don't get involved with big pharma too much. And actually, as an academic, I do try to keep my distance too, because we do know that in terms of marketing, all of the sort of free things that pharmaceutical companies give to people, give to physicians like me in terms of marketing, we know that affects prescribing practices. And so I try to keep myself as independent and as, evidence-based as possible.
And I'm not sure, Maggie, if that question jumped in, like that particular question about big pharma came on when you were talking about you having to get compassionate use approval from the FDA, but just, I think maybe it did. It's just the understanding that what you had to do there is not a common experience. It was a somewhat unique experience.
It's not. I mean, I think, let's see, I've been doing ID for 10 years now, and I think this is only the second time I had to do it. But it is, I think in this situation, Gilead, the pharmaceutical company, was happy to be providing it, right? They want to know if this drug is safe, but I think once they had their clinical trials opening, they didn't want to keep that pipeline open because they wanted to funnel patients into the clinical trials.
Yeah, I think that's about the part where that question came in. I think they were wondering about that. So we just had some more questions come in. Dr. Dayla, did you want to ask yours first? And then if we have time, we can get to these, or do you want me to ask?
Well, I'd rather the students' questions. I guess, I don't know how, if you're going to be willing to, if Dr. has the time, but if the students are willing to hang in, I guess I want to ask a question, because obviously the students heard a lot tonight about science and epidemiology, and you even dug into RNA polymerase and organic chemistry and all these things.
I figure they're closer to that.
Students are actively learning about, which is great because they realize that depending upon what you do, I don't use a lot of organic chemistry, but Dr. Green does, that some of these things that you're learning, thinking, why am I learning it, you will carry forward. But I guess I wanted to ask, and because there are other questions, maybe just a couple bullet answers, Maggie, is the students are digging into their science right now, but what do you think you learned along the way that maybe that you might have even learned as an undergrad that these students can be learning that helped you adapt to this in the workplace, out of the workplace, like professional skills, competency skills that you might have learned above and beyond science?
That's a great question. Let's see. Well, certainly, I don't know if you can learn this from reading a book, but just from my training, being a good listener is really helpful, of just sitting down. And I know we have tons of time constraints, but figuring out what people are actually telling you, whether that's your patients or your boss or your partner, because I think that can really help, that when you are starting to listen to information that's not fitting, you have your radar up, you understand, trying to figure out what propaganda is, trying to figure out who's marketing to you, really having, I guess, not being just an open listener, but a critical listener, of thinking about what the motivation is behind the information that someone is giving you. And I think you can't become a good critical listener without doing a lot of listening.
And the other thing,
although I've done a lot of talking, so.
The other thing that jumped to mind, and then I'll let Tylon ask the other questions, is just the concept of teamwork, right? Like, you had to recognize that you're just one member of many that is going to help the hospital sustain this, the healthcare system sustain this, and that your ability to learn to work as a member of a team and not as just an individual, you can learn at the very early level these students are.
Absolutely. And I think that also just comes from especially with someone like, even you, Dr., David, who is, med peds trained as well and very experienced, you get used to feeling comfortable in a lot of different areas. I've done epidemiology, I've done clinical research, but there's actually more work than can be done by one person. And we need to really rely on our colleagues in other fields to inform us, and to take the lead. It's okay to let them have that. And you just do your part and you do it as best as you can. And I think everyone respects the work that I do in the hospital every single day. And, I'm not necessarily, on TV being interviewed. One of my colleagues from residency actually is on Meet the Press all the time. We do things, we do our roles, and we do what we're good at, but we're all part of that same system.
Kylan, it's all yours.
Thank you. We actually have some really good questions that have come in. The first one is, do we know how the first case of COVID-19 was transmitted from animals to humans? And if so, how did this happen?
I don't think we know that. I mean, we have seen that happen with other coronaviruses. So the MERS-CoV as well as the first SARS. So we sort of have an imagination. Certainly having wild animals in close proximity to humans as they do in wet markets is concerning. But again, these wet markets are prevalent in, and an important source of animal protein for many populations. So just getting rid of them altogether is not the right answer. But we don't know for this case.
Have you found any side effects to any of the treatments that have been experimented with?
So there are, remdesivir, I think, had some, liver inflammatory properties in some people. Certainly there was a lot of concern with hydroxychloroquine of causing cardiac arrhythmias. And in fact, I think that's part of the reason why its safety profile was so poor. Yes, before it had been given to many, many people who had lupus, but now is, suddenly it was being given to people, many, many more people. And so you have an opportunity to see a rare side effect actually show up. But that's all.
Do you think there will be a safe vaccine by 2021?
Maybe. I certainly hope so. The immunogenicity data look pretty good for some of the vaccines. I think there was just a paper in the New England Journal last week on one of the vaccines that's being developed. So I think we're all optimistic. I do trust Dr. Fauci. And so he's actually had a closer look at the actual data than I have. And I think he seems optimistic that we'll have a safe vaccine. When? I don't know. I mean, we have to finish these clinical trials, and clinical trials for prevention are hard because if you're doing everything right and everyone's socially distancing, it takes a long time to get enough cases to actually determine whether your extra prevention intervention, like the vaccine, actually works. If we're all staying apart and there's no transmission, then you're not going to be able to tell the difference between your vaccine and the control group.
And you don't want it to become a politicized issue.
And the vaccine, no, of course not. I definitely don't want it to become a politicized issue. I think we need to see it go through the routine channels that, the FDA is going to work fast, but we want to see the science. And I think, the FDA has already made some recommendations that seemed a little bit too early, but I think that we're all really waiting to see the published peer-reviewed data.
And when the World Health Organization declared that COVID did not have human-to-human transmission in mid-January, what was their reasoning for that?
So I believe that many of the first cases in Wuhan actually had direct contact with the wet markets. And so I think at their time, they thought it was probably similar to some of the swine flu, where you'd see transmission and you might see a cluster because all of these, even some bird flu peaks, where you would see transmission from an animal to a person and from an animal to multiple people. But I think it took a little time to figure out that it was transmitted both from animal to person and then from person to person.
And then one more. As a healthcare professional who has worked with COVID, how does the misinformation being spread make you feel?
Yeah, it's very disheartening, because you know, I do take it personally. Healthcare workers and honestly Americans, we have sacrificed a lot, and we're not going to get closer to being done with needing to keep our economy shut down. I love going to plays, and I'm not going to a play anytime soon, and I'm mad that I can't do that because we're not getting to where we need to with our community spread. So it's disheartening. I've never experienced this before. I don't know how to battle it. I feel like I need to talk to or listen to the social scientists out there, who can help us explain how we start to be together again as a country.
Thank you so much. So I would really like to thank Dr. Green for you graciously volunteering your time and sharing your experiences during what was such a hard time for you. I mean, this talk really, it exceeded my expectations. Dr. Dale said the same thing. I think it exceeded everyone's expectations. And I'm sure everyone here does understand the seriousness of COVID, but I hope that from your talk, they also appreciate the pressures of being in healthcare and the reality of burnout. I'd also really like to thank you, Dr. David Dela, for recommending Dr. Green, for introducing her, and for always stepping up for our students. You've been great the past couple of weeks, especially. This discussion has been recorded, and we'll make sure that it's made available through the Mallory-Wilson Center Canvas page. And if Dr. Dela or Dr. Green, you want me to send it to you, I can absolutely do that as well. Other than that, everyone have a great night, and thank you so much.
Thank you, Tylen.
Thanks, Tylen.
Maggie, thank you.
Thanks, David.
I'll give you a call.